When we talk about colorectal cancer, we are actually discussing two anatomically distinct diseases. Rectal cancer is strictly defined as a malignancy occurring in the final 12 to 15 centimeters of the large intestine, ending right at the anus. While traditionally considered a disease of older adults, the epidemiological data is shifting. For reasons researchers are still working to explain, diagnosis rates in younger demographics are climbing rapidly, making colorectal cancer the leading cancer killer in adults under the age of 50. The clinical distinction comes down to a structural vulnerability. The colon is wrapped in a protective outer layer called the serosa. The rectum lacks this barrier. Without that shield, a tumor encounters less resistance, breaking through the intestinal wall and invading the dense pelvic cavity. Because of this missing barrier, a malignancy in the rectum carries up to a 20% risk of local recurrence, about 10 times higher than a similar tumor in the colon, requiring a different clinical strategy. The disease process begins in the gland cells lining the inner wall of the rectum. When the DNA inside these cells mutates, it overrides the biological instructions for programmed cell death, causing the cells to survive and multiply into an aggressive mass. This specific glandular origin classifies the disease as an adenocarcinoma. This is biologically distinct from anal cancer, which typically develops from squamous cells and requires a different treatment pathway. As the mass grows, it begins to bleed, leading to iron deficiency anemia, visible blood in the stool, and noticeable changes in bowel habits. In younger patients, these warning signs are misdiagnosed as common hemorrhoids, dangerously delaying a proper evaluation. Several known risk factors accelerate this mutation process. A diet high in red meat, chronic inflammatory bowel diseases like Crohn's or ulcerative colitis, and inherited genetic conditions such as Lynch syndrome all elevate a person's baseline risk. The gold standard for locating and diagnosing these malignancies remains the colonoscopy. This procedure allows a gastroenterologist to visually inspect the entire length of the lower digestive tract. Doctors are looking for polyps, abnormal tissue growths that represent the earliest stages of the adenoma-carcinoma sequence. Some, called pedunculated polyps, grow on a distinct stalk. Others are sessile, sitting flat against the bowel wall, making them harder to remove cleanly. If a biopsy confirms the presence of an adenocarcinoma, the tissue undergoes genetic testing for mismatch repair biomarkers. Identifying these mutations is the mandatory gateway step before mapping out any treatment plan. Before treatment begins, oncologists must assess the scale of the threat. They rely on clinical staging, derived from pretreatment imaging, which is later verified by pathological staging, where a histopathologist examines the actual tissue removed during surgery. To build that initial clinical roadmap, a pelvic MRI is required. It allows the care team to measure exactly how deep the cancer has penetrated the rectal wall and whether it has infiltrated nearby lymph nodes. This imaging data populates the TNM staging system, the universal language of oncology, which categorizes the disease across 3 specific variables. The T stands for tumor, measuring the depth of invasion. A T1 tumor is confined to the innermost layer of the bowel. As the number increases, the tumor grows deeper into the muscle, until a T4 tumor physically breaks through the outer lining of the bowel wall. The N represents nodes, quantifying how many nearby lymph nodes contain cancer cells. N0 means the nodes are clear, N1 indicates spread to up to 3 nodes, and N2 marks heavier involvement of 4 or more. Finally, M tracks metastasis. An M1 designation means the cancer has traveled through the blood or lymphatic system to establish secondary tumors in distant organs, most commonly the liver and lungs. If a tumor has reached a T3 or T4 depth, or has spread to local lymph nodes, but remains confined to the pelvic region without distant metastasis, it is classified as locally advanced. This meticulous TNM staging maps the precise coordinates of the disease. By securing this depth data, clinicians determine whether the tumor can be cleanly removed or if it has already infiltrated the narrow margins of the pelvic wall, requiring aggressive shrinking before any attempt at surgery. Because of the rectum's location, tumor extraction requires a multidisciplinary tumor board. The team must carefully balance 2 competing priorities: eliminating the cancer to prevent recurrence and preserving the patient's normal bowel function. For early, small T1 tumors that haven't reached the muscle layer, Surgeons can sometimes use minimally invasive techniques, like endoscopic submucosal dissection, removing the tissue from inside the bowel. Larger tumors in the middle or upper rectum typically require a low anterior resection, or LAR. The surgeon physically cuts away the cancerous section of the rectum and the surrounding tissue. The remaining healthy colon is then pulled down and reattached to the top of the anal canal. This connection, called a colorectal anastomosis, maintains the continuity of the digestive tract and preserves near-normal bowel movements. If the tumor is located at the very bottom of the rectum and has invaded the sphincter muscles, an anastomosis is impossible. The surgical team must perform an abdominoperineal resection, removing the rectum and anus entirely and creating a permanent colostomy on the abdomen. The severe anatomical and psychological consequences of lower pelvic surgery drove oncologists to search for a way to aggressively shrink these tumors before operating. For decades, the standard treatment sequence for locally advanced disease was rigid: low-dose chemoradiation, followed by major surgery, and finally systemic chemotherapy to clean up remaining cells. Today, clinical guidelines recognize a new standard: total neoadjuvant therapy, or TNT. The core mechanical shift of TNT is a timeline reorganization. It front-loads full systemic chemotherapy and radiation prior to any surgical intervention. By delivering full-strength chemotherapy first, oncologists attack microscopic cancer cells circulating in the bloodstream early, while simultaneously maximizing local tumor shrinkage in the pelvis. This chart from the Rapido trial proves the efficacy of this approach. Patients receiving TNT saw their pathologic complete response rate, meaning no remaining cancer cells were found in the surgical tissue, jump to 28.4%, compared to 14.3% under standard care. With more tumors effectively sterilized, the data also showed a lower rate of disease-related treatment failure. Beyond tumor shrinkage, front-loading the drug solves a major compliance issue. The Prodigy 23 trial demonstrated that patients tolerate intensive chemotherapy far better before enduring major abdominal surgery. When chemotherapy is administered early, 81% of patients successfully complete their full course of treatment, outperforming the standard postoperative delivery rate of 75%. The high response rates of total neoadjuvant therapy lead to an extraordinary outcome for a subset of patients. The tumor vanishes entirely on imaging and endoscopy before surgery begins. For patients who achieve this complete clinical response, specialists utilize an alternative pathway called the watch and wait strategy. Under this protocol, the planned radical surgery is bypassed. Instead, the patient enters a regimen of intense, high-frequency clinical and radiological surveillance to ensure the tumor does not return. This provides massive quality-of-life benefits. The patient avoids the trauma of resection, prevents the need for a permanent colostomy, and preserves native bowel function. For these patients, watch and wait fulfills a major goal of modern cancer care, achieving complete remission while bypassing the life-altering complications of radical pelvic surgery. For the majority of patients who do require resection, the physiological risks are immediate. Intestinal perforation and dangerous leaks at the anastomosis connection site are severe threats in the days following surgery. Long-term functional impacts are also common. Operating in the crowded lower pelvis frequently impairs urinary and sexual function, and patients regularly manage chronic bowel urgency, known as low anterior resection syndrome. The radiation required to initially shrink the tumor carries its own toxicities. Because the treatment targets the reproductive organs, it poses a direct threat to fertility, making family planning consultations mandatory before treatment starts. Following treatment, the patient enters a strict surveillance schedule. Routine CEA blood tests, regular CT scans, and routine colonoscopies are utilized to monitor for the persistent 20% threat of local recurrence. Treating rectal cancer is a lifelong clinical contract. The anatomical vulnerability of the lower pelvis ensures that even after a tumor is destroyed, the patient requires vigilant, multidisciplinary management to sustain their survival.